Have you ever read the Modern Love column in the New York Times? Whether you're a devoted fan or have never heard of it, Modern Love is a hugely popular weekly column in the Times where readers submit their compelling and emotional essays that fit in the category of modern love, with all its relationships, feelings, betrayals, and revelations. So, how is a column about the twists and turns of love connected to how to skillfully communicate important information like complex scientific and medical topics? And how can a column about love and relationships help you discover ways yourself to boost the impact of your own communication during critical conversations, presentations, and interactions? Let's find out. With us this week is Erika Ramsdale, MD. Erika is a geriatric oncologist, NIH-funded researcher in cancer and aging, and a data scientist. The New York Times published Erika's essay in its Modern Love column under this headline: "My dog had trust issues, so did I. We needed a steady presence in our lives. Enter Kevin." Here to talk about our Modern Love essay is Dr. Erika Ramsdale. Welcome to the show, Erika. Wonderful to have you here.
It's so wonderful to be here. Thank you so much.
There is just so much in your Modern Love piece. I loved it. And of course, we're going to link to a gift article in the show notes accompanying this episode so listeners can read it themselves. Definitely worth the read. And when I read it, it really landed on several levels for me. And the one I'd like to start with is the idea that you bring up about facts and feelings being both important in the practice of medicine. So early in your piece, you write about how medicine had called me with a message of job security and financial stability, not human connection and healing. Like many doctors, I thought my primary duty was to counter uncertainty with facts. The field of oncology was and still is breathtakingly prolific at generating new facts, and I had a growing sense of mastery over doubt and disease. And then towards the end of your essay, you write, "I'm sitting with patients in their anguish and dread when facts are insubstantial." I would love for you to share more about your thinking as a physician at both those times in your life, which perhaps shifted somewhat, and what was behind that change.
Yeah, so I might take you back even further to before I was a physician, and I was sitting in my medical school interviews. And I really remember the impact of one of those interviews. It was at the school I ended up attending. And this interview was with a senior faculty member, this very experienced, very authoritative physician, lots of gravitas. And he's looking at me across the desk and he says to me, "What are the three most important characteristics of a physician?" And I have no recollection of what my first two answers were. Maybe compassion, intelligence, who knows. But I remember that my third answer was intuition. And this really upset him. He said, "Young lady, we deal with facts in medicine. Intuition has no place here." And he seemed really affronted, and I felt really ashamed. I felt like a silly little girl. But in this other way, I was also comforted by his understanding of what medicine was doing, because it's comforting to have certainty and to be grounded in facts. And so even though I know comfort is a feeling too, we do like to pretend to ourselves that science is all about facts and certainty. But if we think about it, science is really built on a cornerstone of uncertainty and discomfort and trying to figure it out. So that's one story. And then I think it's true what I say in the article that my initial draw to the field of medicine was financial security. So I came from a turbulent family background. I was constantly told I should never rely on a spouse or anybody else for my financial, support. I really had to be totally independent and secure. But what I didn't mention in the piece is that I was then also propelled by anger over my own misdiagnosis. So I was diagnosed at around age 19 with inflammatory bowel disease, which is an autoimmune condition that can be serious, and it was in my case. But my symptoms were ignored for about 18 months after onset of them. And I was dismissed as anxious and probably histrionic. And I kept going to the doctor and begging for someone to help me. And I honestly could have died from this misdiagnosis, and I got really sick. I didn't get support and understanding from my doctors, and it was really an all-around awful experience. But I think even with that background, I did what I thought I was supposed to do once I entered medicine and what the culture of medicine was teaching me, which was I was supposed to dispel uncertainty. I was supposed to be an expert. And so you start out in med school, you learn this avalanche of facts,
Mm.
and then you go on to discuss cases about diseases, and everything about the training is preparing you to find an answer, the answer. And that sort of starts to lull you because you start thinking in terms of the disease and these problems that are tractable if we can just have more facts, if we can just know more. And so, even despite my own experience with illness, I don't think I was mature or confident enough, at that point early on to examine that closely and look at what a doctor really should be doing. And I do think since I was in school, we've gotten better about medical school education and understanding those other parts of what the doctor does. But what I absorbed in med school was, I'm there to provide facts.
Mm.
So I think reducing uncertainty does comfort people. So there is a role there for facts, but there's many times where facts really aren't the point, like I say in the piece. So I'm a cancer doctor. I treat older adults with cancer. And so maybe I'm sitting with someone and maybe their family, and maybe I've just told them some really devastating news, or
Mm.
maybe they're having a hard time with their treatment, what have you. So me lobbing a lot of facts at them in that moment is not helping. And I think a lot of people will say that doctors still do resort to that. Maybe it's to cover up their own discomfort when there is no answer or facts that are going to help. Because sometimes the best thing I can do is just be a presence. I can hold their hand, I can understand their feelings and reflect them back or reflect back my own feelings. And one of the things that really surprised me in this field is how often people want to find humor in the darkest places. And so we end up laughing with each other in the midst of this horrible situation. So I think to go back to your question, what's behind that change or that shift actually ties back to that interview in medical school. So over time and with a lot of experience, you develop that intuition about what people might need from you in that moment, in that room. And I follow that. And it was a lot of trial and a lot of error, but I learned that people need more than facts from me. And I still don't read the room right. And usually my patients will let me know when I haven't. But when I first go into the room as a physician in these really fraught circumstances, especially when I'm first meeting someone, I know I have seconds or maybe minutes to really make that first impression and develop an early rapport that can blossom into a partnership. And that's one of the most critical parts of being a physician. So my expertise is important, but I think that's even more. And I treat older adults with cancer. They've lived their whole lives. They have these rich inner worlds. They know what they feel. They know what they prioritize. And if our partnership doesn't embrace that and the ebbs and flows of those feelings, then I will fail them as a physician. And so that's what I believe now.
So much there. I just will say as an aside, as a parent of a child who has IBD, and has gone through multiple surgeries and so forth, I know from a close-up perspective how difficult and dangerous that particular condition can be. I can't imagine how he would have done if we had ignored what he was going through. The other thing that you touched on, Eric, is so important, is about those first critical seconds when you're having that interaction, trying to read the room, and it's really hard. And I guess the last thing I'll say, as a word nerd, I think this reflects what you were talking about with feelings and other pieces, or whether it's intuition, is the artistry of medicine. I love to talk about the roots of different words. And when I talk to doctors in my talks, I talk about the healing arts and the artistry of medicine, and get them to understand that's part of their job, not just a separate kind of thing that's a nice to have, but built in to the profession. So when I read your piece, I really heard echoes of that in your writing.
Thank you. I definitely believe and have believed more so over time in the art and the importance of the art and the importance of tapping into that intuition, which is really just built up experience of being a human, if you think
Mm.
about it.
Yeah, yeah. Yeah, so true. And you've talked about the erosion of trust in society. We're really talking about different feelings here. And trust is such a powerful one. We've seen trust, even though it's high compared to other professions, but trust in science has eroded. It's gone down the last several years. And I'm wondering how you think, why you think that is. And also, do you think it has to do at all with some of this communication pattern or teaching or training? As you point out, it's gotten better in the years that since you graduated medical school and you practice. But thinking about this erosion of trust generally in the public's mind when it comes to scientists, why do you think that has happened?
Yeah, it's such a profound question with probably so many facets. And I know that people's entire careers are dedicated to answering this question and books written about it. I'm certainly not an expert in all the facets. My lenses are really coming from the clinic. And then to some extent, as a data scientist, I think there's pieces that
Mhm.
I can talk about. We're also this week, last week, in a particularly chaotic moment in time related to science and its role in society. So I think examining this question is just getting more and more critical. So there's a lot of pieces that may have to do with policy, culture, history, a lot of which I only know very little about. So I do know if you ask my spouse about this, he's a theologian, he's an ethicist.
Mm.
He's studied the
Mhm.
history of religious thought, which intersects in interesting ways with science.
Yeah.
He'll say, look, I've always had this very skeptical, rebellious streak, and you can't tell me what to do is really baked into the
Mhm.
founding of our country. And scientists and doctors, we like to tell people what to do. It's part of our role to make those recommendations. So there's that in the background. And then as in terms of the data, I really look at this transformation in information access over the last couple of decades, especially. So when you think about years and years ago, decades ago, and before, you used to have scientific knowledge as this sort of priestly sacred knowledge. There was a gatekeeper. It was only kept and known and passed on between these practitioners in medicine. It was only priests that were allowed to read the Bible for a long time. So
Uh-huh,
regular
uh-huh.
people couldn't just easily go out there and get the medical literature, and especially a non-jargon filled version of that literature or an interpretation. They had to go to their doctors to get that. So doctors and scientists maybe had more of a gatekeeper role, and maybe that wasn't intentional, but just the way the infrastructure happened to work. And now you can go out and do your own research, which more and more involves perusing the internet. And we all know there's a lot of very questionable stuff on the internet, and a lot of it's just wrong. And so I would say one of the most important parts of expertise is knowing what you don't know. And that takes so much training and mastery and grappling with a field of knowledge for a very long time to get a feel for that. And I think there is a downside to the democratization of knowledge, and especially the knowledge that's being disseminated through this anonymous internet. And it's that people can be convinced by a lot of things that either aren't true or may have a grain of truth but are oversimplified, because we all of us love the really straightforward narratives that are all tied up in a bow. But we know
Right.
that things like how to treat cancer, that's anything but simple. It's very complex. And then I've also noticed that people can state things on the internet, especially with a high degree of confidence. And confidence does impact how people receive that and how likely they are to believe in it. I think this unfettered access to knowledge, which I think is an overall good, don't get me wrong, but it has this kind of dark side that we have to contend with, and that the world is really complex. And the way that I deal with that in clinic is I engage with these grains of truth, because there almost always is one in what people are believing and saying. And instead of shutting people down or telling them they're wrong, I'll engage with them and try to engage with their feelings or their fears. And for example, I get a lot of um, cancer cures are being hidden from us. If I take apple cider vinegar or I take maple syrup or I do these things, I can cure my cancer. And that's what I read on the internet. And I tell people, look, I would be the happiest out of work oncologist you've ever seen if it were that simple that
Mm.
the cancer cure all's in your kitchen cabinet. And then I engage with how complex these things really are. And people do come along with me.
It's really It's fascinating to me the way you're approaching this too. And I absolutely see what you're talking about with respect to the grain of truth, because that's part of the recipe for disinformation is it has some tiny bit of truth to it. And then you talked about when you were saying, first of all, you engage directly with that belief, say that apple cider vinegar is going to cure the cancer. So you don't ignore it. And then you talked about feelings with that engagement, which I've always believed is really the way to deal with misinformation. It's not more data. It's first these feelings that you try to address and uncover and talk about and not ignore in those interactions.
I think I'm sincere when I say, gosh, I really wish you were right about that. I really wish that could be the answer. I'm going to use anything as an oncologist I can that has data to help you and help your cancer. Um, and so I express my own feelings about it, and then I'll take them through. Often I've spent a lot of time looking at why some of these grains of truth exist and how they've blossomed into what they are. So I can take them
Mhm,
back to where this knowledge came from, where this
mhm,
grain of truth came from, and link it back that way. And people are curious, they're interested. You have to engage their curiosity, engage their trust, and meet them where they are. And I would also say I'm somewhat sympathetic to people who say that science, in some cases, has become too elitist, because I feel like sometimes it's almost like we've overcorrected to this glut of misinformation by maybe being rigid ourselves or over prescriptive as scientists. We have our own emotional reactions to this doubt and this erosion of trust. And I am not saying at all and would never say that scientists are not doing their absolute best. We are. By and large, we're all driven to help people. But I do understand the frustration that people have. And it's also true that science has not always behaved in trustworthy ways, particularly to certain groups of people,
mhm,
or because there are perverse incentives like money motivating scientific output. Those things happen. And
mhm.
this doesn't apply to the vast majority of science that's going on, but we do have to understand how it can damage trust and be aware that we cannot react solely from the place of our own emotions and fear and anger about that.
Yeah, and I want to ask you a follow-up on that because that is so important. That reaction, it's completely understandable from my perspective. Someone who's spent decades of their life working on particular, say, let's just say, for our example, cancer, and to have someone come in, a patient come in and basically say, curing it is as simple as mixing these household ingredients together and drinking it every 3 hours or something like that. And that emotional reaction that the physician could have. I guess my question to you is that's a normal emotional
It
reaction.
is.
How, yeah, how do you see it expressed in, say, the response? You've talked about, more generally speaking, you've talked about your response is really initially like an emotional one as well. So I would argue like that's the way to do it. Doing it with facts and data doesn't do it because that's not what they're feeling at the time or really needing at the time. So I guess my more general question is when it comes to scientists understanding that response and how that should be colored, which is initially, I would say, and research has been done for a long time on misinformation kind of touches this. It is with initially with an emotional and attempt for engagement where the person is, not to just dump data and studies on them. How do you think scientists react more generally or more broadly, in whether it's training that they're receiving or things that you've observed when they are talking to a patient who tells them something like that?
Do you mean how do I feel like they are generally responding, or how do I feel like we can shift that, or maybe both?
Yeah, maybe the first one, and maybe it does go back to younger, physicians who are just starting out and how, and maybe even more experienced physicians, do they realize this? Do they realize that the response makes so much of a difference and perhaps the default would be the safe place, which is the facts?
Yeah, that's a great question. And I can certainly speak from my experience in saying that, yes, there was definitely a long time in my practice where I didn't fully understand my emotional responses. And one of the reasons to acknowledge that there are emotions that are involved and not just facts is because once we acknowledge that, we can start to work on that and
Mhm.
start to examine our responses from the more informed position and then start to modify that behavior and modulate how we respond. I think it is a lot of the things we face in the clinic or anywhere where we're having these tough discussions. People are upset, they're angry, they're having a lot of feelings that are coming at us. And we can get really identified with our role as physicians, as scientists. So a lot of what I'm doing in the clinic is I'm stepping aside. Like, here's my role as a physician, and they're angry about what I'm saying, but I'm not going to take that personally and react from within. That's not going to do any good. I do have to react with authentic emotion, but I have to understand what I'm doing and how I'm doing that in the moment to really meet them where they are. So it's not that you take the emotion out of it. In fact, you just are a lot more conscious about the emotion that you're bringing into it and that you're
Mhm.
bringing authentic emotion because people can read that. People are
Mhm.
very
Mhm.
smart about reading
Mhm.
that authenticity. So I'd say I've thought a lot about how you train that. I don't know. There probably are people out there that know how to do that. But for me, it was just something that evolved a little bit over time.
Mm.
And there's components, I think, to communication, either as a scientist or as a physician. And because you asked about how can we think about training physicians
Mhm.
to do this better? I don't think we teach physicians and scientists enough about how to communicate. The first thing is that distilling this complex scientific information into kind of everyday language is really hard to do.
Mhm.
It's taken me years and years to learn how to do, and is its own skill set, separate
Mhm.
from medicine, separate from science. So I don't know if this is something all scientists can be trained to do or only a subset, but I also think it's really hard to communicate uncertainty well.
Mhm. Yeah.
That uncertainty stimulates anxiety, fear, and it's very hard to wade through that when you try to communicate the real uncertainty that we have as scientists, because the whole basis for the scientific method is uncertainty. It comes from a place of not knowing. But then in the clinic, for example, it's threatening for us too, because we worry we come across as like an idiot if we talk about our uncertainty. And I feel like there's a real sense, especially in the social media era, that we can't ever adapt our views on things. And that's really an anathema to science communication because what we know shifts over time and what we
Right.
understand
Right.
shifts. And so there
Mhm.
has to also be this societal tolerance of uncertainty and a better understanding that this is science working. This is how we act on the best information we have at the time. And then new information may come along and we may act differently. But interestingly, I have noticed that this doesn't really, all of the stuff I'm describing
Mhm.
doesn't happen in the clinic as much in one-on-one settings. So when we're facing each other, when I'm facing a patient and
Mhm.
we've developed this sense that we're in it together, a lot of this fear response goes
Mhm.
away in me. I see it going away in the patient. And I used to think I had to have all the answers as a physician and that my patients would lose faith in me. If I say I don't know, they'd mistrust me. And I found out that it's actually the opposite. If I say I don't know and I show this vulnerability and humility, this actually increases trust, and I think that holds probably across a lot of scenarios. And so that may not work in every medium or every situation, but where I live in this one-on-one world, that's what I see.
Yeah. 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 So key. Just wonderful. Um, I want to ask you about your essay now specifically because in the essay, you're telling really an emotionally layered story, maybe several stories perhaps. And you noted specifically about storytelling. In your words, you said storytelling has a deep power, a radical power. It's an antidote to loneliness, it's medicine. And those words are just so powerful. And I'm wondering if you could tell us more about what you mean by that and perhaps when or how you've seen the medicinal power of storytelling, either in your own practice or maybe secondhand with working with your colleagues.
Yeah, and thank you for those words. Stories have always been really important to me. I think they're important to humans just in general. That's not unique to me. But I think stories are, number one, a key way that humans have always passed on knowledge. This is deeply ingrained. And the truth is, we're more influenced by stories than, say, statistics, like a
Mhm.
recitation of facts or statistics, because stories have this emotional impact. We know that people rely on emotions to make decisions, including among scientists and physicians. We're not exempt from that. So, even people who are trained to understand evidence and data. So, there's this fascinating study that one of my mentors did and wrote about, and it showed that the surgeons can be highly influenced by this bad outcome they saw or experienced. So, after a bad outcome, they shift their practice or their decisions, even if the statistical probabilities haven't changed, the guidelines haven't changed. So they're reacting to an anecdote that so disturbed them or distressed them
Yes.
that they maybe become more conservative in their decision making, for example. And I find that interesting because in science, we say anecdotal evidence, story based or case based evidence is really weak evidence in the hierarchy of evidence, but it's the thing that works the most strongly on our human brains. I think that's one of the reasons stories have this radical power. And the other thing that's always fascinated me about stories is that stories encode really dense information. And what I mean by that is I can understand very complex, interconnected things like the health of my older patient, for example, much better through a story than through
Mm,
a list of facts.
mm,
So I'll ask them to tell me a story about what they did yesterday, or a story about their family, or something like that. And it will often tell me more in a shorter time than a review of their labs and vital signs and discrete facts. So I can learn a lot about their functioning, their relationships, their cognition, all these things that most influence how they're going to do with their cancer and their cancer treatment. So I think we use stories to think as tools to think in a way that machines can't. Even with all this talk of like artificial general intelligence, I don't think machines can do that yet. And then lastly, I'd say the stories we tell each other are really how we connect as humans also.
mm,
When I found out the Modern Love piece was gonna be published, I wrote this piece. I had talked to my neighbor about how I met my husband. I told this kind of the cute version, the meet cute version of the story, and she said, "Oh, that's really funny. You should submit it to Modern Love." And I said, "Okay." But when I sat down to write it, something very dark and vulnerable came out, and I still sent it in. It was cathartic. And I didn't think there was a chance at all that it would be chosen to print. It was this very vulnerable piece. And I was putting it out there for people to judge, and now it's gonna be published and read by a lot of people. And I was most worried actually about my patients reading it and knowing all these dark and vulnerable things about me. But I would say once it was out there, what I actually felt was lightness and connection, and it was really healing for me. And then all these people started telling me their stories that maybe they hadn't told anyone or told very few people. And
right.
so it was a sort of cascade of connection that was really powerful. And then you asked, how has this shown up in medicine or how is it medicine? It's certainly been medicine for me, very healing, like I said. But I actually came to medicine through stories. When I went to medical school, I thought I wanted to be a pathologist because I wanted nothing to do with actually talking to patients. I was introverted, I was very awkward. And so I started pathology training, but I had this very wise mentor, and he said to me, "You need patients. You need them more than they need you." And it was really painful. But those are some of the most impactful words anyone's ever said to me. So I appreciate them. And I decided to switch my direction and go into medicine. But before I committed to this, I showed up in the office of Martha Montello, who's an ethicist who does narrative medicine work,
Mm,
asked for help. And under her direction, I basically read all I could get my hands on about how patients tell stories about their illnesses. There's a lot of memoirs out there, and there's a word for them. They're called pathographies. So these memoirs about illness. And that was my way of approaching the art of medicine through these stories in an approachable way for me, who was deeply scared of interaction. And then I built
mm,
from there. So stories are really the core of what I would say is my moral formation as a physician. And there's so many stories, of course, that have touched me in my career
Mm.
that I carry with me. But when I read your questions that you sent over and I was thinking on them, there was one story that kept coming up in my head, and it's from very early on in my career, so it doesn't actually paint me in the most flattering light. I was an immature physician. But when I was a medicine resident, I had a panel of patients for whom I was their primary care doctor.
Mm.
And I had one patient who had a lot of trouble with alcohol addiction, and it was very seriously affecting her health. It had basically destroyed all of her relationships, and it was very difficult for me to deal with her because she was making all these choices that I thought were just so foolish and destructive, and of course, I knew she had an illness, but it was all very triggering to me because alcoholism runs in my family. My uncle died very young of liver failure from alcoholism. One of my parents struggled with it, and it was the source of a lot of trauma and grief for me in ways that I may not have been really aware of. So on one clinic visit, she came in and she had just gotten sicker and sicker. She wasn't taking any of her medications. Again, I felt like she was being so self-destructive, and I'm not proud of this, but I lost my cool in the clinic room. And I started telling her the story of how alcoholism had really destroyed my family,
Mm.
and it was destroying her, and she was gonna die. And I started crying, and I, like, threw these papers on the floor and stomped out of the room. It's definitely not my greatest moment as a physician, and I don't recommend the tantruming, but I told her the story of where I was coming from and was really exhorting her to make a different choice. And shortly after that, I moved on to fellowship training in oncology. I had to hand off that panel of patients to another physician. But several years later, I was actually in a moving van. I was driving cross country to start my first job as an attending physician, and my phone rings, my cell phone rings, and it was her. She had somehow gotten my number. And she said, "Do you remember me?" And I said, "Of course." And she said, "You saved my life. When you shared that story, when you lost your cool and did out." She read, even though I'm not proud of how I acted and I would certainly do it differently now, she responded to that authenticity in that interaction, and she felt that I cared, and she was preparing to give her testimony in her church, and she was gonna tell her story in front of her whole congregation, and she asked me if I would be there. And so it's this really full circle moment of the story. Now she was gonna tell the story about how that was medicinal for her. I really wish I could have been there to hear it. I was on my way across country, but that was a story that came up where you really saw that impact of people telling stories to each other.
Thanks for sharing that. I know it's going to have a huge impact with listeners. I want to ask you, Erica, as we wrap up, and you've touched upon these different pieces, but thinking about advice in this realm that you'd like listeners to hear, whether they're thinking of going to medical school, they're already practicing, or they just need to have difficult conversations about tough topics, what would you encourage them to think about based on your own experiences?
Yeah, so I think you can get a very long way with humility and curiosity. And in fact, maybe those should be my two answers to the three important characteristics of a physician, and maybe for scientists too. I would love for all of us to get really curious about other perspectives and find that common ground and those grains of truth and employ there's a book that I love. It's by Chris Voss. He is or was an FBI hostage negotiator, and he wrote a book called Never Split the Difference. And he talks about techniques for what he calls tactical empathy. And I
Mm.
love this. It sounds, I don't want to frame it as manipulation. It's not that. It's actually what I would say is the art of persuasion. See, he gives some really good techniques that I use all the time. I had to practice them, but that I use all the time in clinic that really clear the space for that authenticity to come forward, and practicing those communicative techniques and that tactical empathy, it clears out some of that emotional junk that might otherwise get in the way. So I would love for people to maybe read that and think about how they can employ some of these techniques because there are people who are thinking about how to train people to do this. Because again, as much as we think we're purely rational creatures, we're not. Lobbing facts at people doesn't tend to help much. We're very emotionally attached to our interpretations of the world, and that includes us as scientists. We're very attached to a scientific view of the world. But if we can really loosen that grip and center the relationship between people rather than the two poles, the relationship itself, I think humans naturally want to move closer to one another and want to persuade and be persuaded. That's my experience of humans one on one. And I do think storytelling is a real key piece of this, and it's not always safe to be vulnerable. I understand that, but sometimes, as it certainly was for me, it's very healing. And being vulnerable opens the door for others to be vulnerable and tell their stories in turn and feel safe to do that. And then the other thing I'd say is that you have to give people time to evolve in their understanding. I've noticed this and it distresses me when we tell patients very bad information, for example. I go in the room and I say, "You are dying of your cancer," or "The treatment isn't working." I've noticed that we expect them to immediately agree with that and immediately understand that. And often patients are very angry. This is an existential threat that they're hearing, and they're angry at me. And they say, "No, that can't be." They don't want to believe it. They're not believing it. And a lot of times I've noticed we label those patients as like in denial, or they don't have coping. They're not coping with the information that's true. They're not dealing with the truth. But often, if we give them time to evolve, they come back around. We can't just drop these things on people and expect them to immediately shift their entire perspective, especially with serious conversations or places where people might be more divided. So I think you need to give people time to evolve, and then you need to make sure you're attending to your own evolution and making sure that you're flexible and you're examining your own emotions and how they're affecting how you see the world. And then the lovely thing about medicine is that I get to see people face to face. And I think face to face communication and conversations are the best because I'm just really not sure how much good influence I'm seeing happening over social media or just the internet in general. So the things I learn in clinic, I definitely apply outside the clinic. And patients have been very good teachers in terms of how to communicate the really tough stuff. So I don't have any big answers or great solutions to the bigger problems of misinformation and societal mistrust. And the big picture honestly gets pretty overwhelming for me at times. But I just think that small pebbles still make ripples. And so I focus on that. And two people sharing stories and meeting each other where they are can really shift perspectives. And I've seen that over and over.
Dr. Erika Ramsdale, this has just been such a powerful, high impact and vulnerable interview. And I really do think the vulnerability has such a power with people, leading to authenticity and trust ultimately. So thank you both for taking time out of your busy schedule to share with us and with listeners, and also for what you do every day.
Thank you so much. I've really enjoyed this conversation. So thank you for inviting me on.
And listeners, thank you for being here on this episode of When Science Speaks. And I hope you'll be back next time for the next episode of When Science Speaks.